joint derangements should be reversible in most cases. That is, if there's a movement that's going to fix it, likely there's a movement that makes it worse. And I had an interesting scenario today that has happened many times with patient interactions, of course, but I wanted to know if I could make something worse because I wanted more credibility to my pursuit of moving the low back for someone's right knee pain. And I think we're on the right track. I just wanted a little bit more evidence, so to speak. So for this patient, extension helped a little bit, but not entirely. And then we moved on to flexion rotation, and we were curious if that was the right one. And without telling the patient, I wanted to see if we could make it worse. That's what I wanted to do when I asked the patient to do repeated lumbar flexion and sitting. So just sitting at the front of the chair, going down, rounding the low back, grabbing the ankles, in this case for some overpressure, and pulling 10 or 15 times. Now, before I had him do this, the baselines were lumbar range of motion, looked good without pain and standing, except for a mild loss of extension. Knee pain with stepping up and down stairs, and then knee range of motion normal, hip range of motion normal, hip flexion 5 out of 5, hip abduction 5 out of 5 on that side, and hip extension 4 out of 5 on that side. So I know that I tend to see muscle strength change the most quickly, the fastest. So I think of that as a mechanical advantage problem. I don't really know how else to explain it. I don't think we are irritating the nerve roots in the lumbar spine that turn off the muscles to the hip. Maybe we are, but I think of it as if the joint's not mechanically working well, then the muscles and tendons that surround it can't do their job as efficiently or effectively due to mechanical advantage. But again, that's just a theory of mine. What's more important is that it's observable cause and effect. So I had those hip baselines, lumbar range of motion baselines, and the step up, step down baseline for the knee pain. Now, I had him do 10 or 15 lumbar flexions, which yes, is also hip flexion. I get it. Lumbar flexion in supine, where you bring the knees to the chest, is also hip flexion. If I really need to be nuanced and distinguish between what is causing the change in the presentation or the change in the baselines, is it lumbar flexion or hip flexion? I can kind of get the hip out of the picture by doing lumbar mobilizations and extension or other maneuvers. But when you flex one, you flex the other. So it's more difficult to rule things in and out when it comes to flexion. Nonetheless, we think he has a low back problem. His hip moves well and doesn't have any pain. Anyway, we did 10 or 15 of these, got up, lumbar range of motion. I didn't bother testing. I went straight to the hip, looked at hip flexion. Now it was 4 minus. Hip abduction, now it was 4 minus, and hip extension, now about 4 minus. So everything went down and he could really observe it. He's like surprised that it was so much weaker. And I've had patients tell me they think I'm pushing less hard or harder, whichever way it goes, to corroborate their kind of notion that why would their muscle turn on or off so quickly. So I like when patients can see it because then they can appreciate that, oh, there's something going on. I don't think a healthy joint, if I flex it or extend it or side glide it or side bend it 10, 20, even 50 or 100 times, if it's healthy, it's stable, it can take that motion and your muscle strength is not going to be trashed. You can do that self-experiment. You can test muscle strength and move in a certain direction and then retest it again. A manual muscle test is nice because we have a very specific force applied to a specific place in a specific position, but a functional strength test like a push-up or a pull-up can also do the trick. So he noticed it, I noticed it. We could agree that it was worth pursuing the back a little bit more because we could see that it really trashed him when we did lumbar flexion and sitting in terms of strength. Do I think that that strength deficit is what's causing maybe a mechanical disturbance in the knee and pain in the knee? I don't know. It seems a little far-fetched to think 4 minus out of 5 pain, or excuse me, weakness in the hip flexor or hip abductor or hip extensor could create instability at the knee and therefore pain with stepping up and down, but maybe that is the determining factor. But we looked at extension and those muscle tests got better, and then we looked at flexion rotation, which we were pursuing the week prior, and the muscle strength in those 3 hip muscles directions was markedly improved, 5 out of 5. I couldn't budge it. So we took other baselines into account, mostly the pain with stepping up and stepping down, lumbar range of motion, but also those hip baselines. I don't even know if I had tested those hip muscle baselines on previous treatments, but I looked for more today, knowing that, again, muscles tend to change more quickly with disturbed joints than the other things. I looked for them because I wanted to have more things to test to gain, again, evidence that we were onto something by moving the low back. And because it was worse with flexion, better with extension, and better even more so with lumbar flexion rotation, legs to the right, we came to the conclusion together that yes, we were on the right track with moving this direction of the lumbar spine for the presentation of isolated right knee pain.